What do you think some of those consequences are with respect to patient care? We are seeing more of the delivery of oncology go into the hospital setting. Has that had any observable impact?
I think the most immediate effect of this consolidation has been closure of a lot of rural clinics. And with this new law, I don't see, it may be still that facilities that own providers still have an incentive to create clinics in rural settings, but they're not going to get that facility payment and they're not going to get the enhanced payment. They'll still have the 340B pricing, but not all hospitals have that. So I think maybe the net effect of this law will be to decrease access, or at least it won't improve it.
Well, and I think the other interesting thing is, so if you go back 40 years ago and we think about what cancer care was like, it was really centered in a lot of big facilities, and patients had to travel, and you didn't have it in the rural area. And what's kind of ironic is we've come full circle, because now we have more health systems building large buildings, and in a lot of cases, and people hate me saying this, but it's off of 340B profits. And so they're building these, and what they're doing is they're closing those less profitable rural centers, and that's where we've seen a real impact. So the irony of it is we're actually digressing back again. We're de-evolving into a system of where we're going to see beautiful buildings and providing cancer care, but more centralization and less basically out in the community in the rural settings. And that's disconcerting, because what that means is a lot of people think when a cancer patient has to travel, they will do anything. And study after study have shown that no, in many cases they can't, they won't, and it only ends up where their disease progresses and they end up in the emergency room somewhere, that they're in the hospital.
What are you saying?
So I think that there's also an out-of-pocket cost differential to the extension that some of these, and it'd be interesting, Ted, there's been like kind of statistics on how quickly the field of oncology is migrating into the hospital outpatient setting at a kind of a rapid clip, and I've seen varying estimates, but out-of-pocket costs could certainly change if patients are on the physician fee schedule and subject to kind of Part B kind of premiums and co-payments, which we know has also been changing just from a Medicare standpoint. So in the end, how a patient might see this, I think you're absolutely right. Patients prefer to stay local. Will they have those local options? Maybe not as a result of this. And will they also then potentially be subject to some out-of-pocket costs because they might have, not the hospital-based facility, but something that's on the Part B sensitivity. So I think there's some interesting kind of dynamics, but I agree with Ted completely. When I saw this, first of all, it's interesting. I'm not defending kind of these larger institutions. They hate this term site neutrality because they think it really takes away from what they see as some of the differentiators, the academic setting, the teaching, multidisciplinary rounds, et cetera. So when you talk to the larger institutions, they're very upset because they think that this conversation around site neutrality just kind of takes everything to a lowest common denominator when they really do feel like they offer something that's truly different. My retort back to them is, you'll have to demonstrate that you really offer something different to your original example. Right. But I think on the patient side of it, here's what's interesting that we haven't, kind of dissected. When you talk to ethnic groups and minority groups, there's a palpable perception that the institution-based treatments are sometimes better. It's the same reason that we see ethnic minorities going to the emergency rooms for care. They feel like their care is actually better and that they can get all their services delivered in one setting. So I think that as we know that there exists disparities of many kinds, disparities of care delivered in community-based settings versus hospitals, there's also kind of another exaggeration of disparities kind of along racial and ethnic minority lines, and it leads a little bit to the rural conversation. We're making things a little worse at times, I think, with some of these policies.
We are. I think the biggest thing, the driver overall is, again, and I'm saying there's many hospitals that provide the greatest care in cancer care, but the problem is it's well known that the hospitals basically cost more for Medicare, for the private payer, but most importantly for the patient. So if you even look at studies by Milliman, Avalier, Moran, BRG, go right down the list of big, well-respected national policy firms have looked at this and shown there's higher care. And I'll tell you what's a little disconcerting, and it's kind of interesting. You know, the argument, the age-old argument, you think back when you were on working for Senator Kennedy and on HELP staff, and think of it was always this around the MMA that oncologists basically prescribe drug based on the margin. Well, in the latest BRG report, they actually found that looking at 340B hospitals versus community clinics,